I'm happy to talk about the 𝗖𝗿, a useful adjunct in vascular surgery. And this session is sponsored by ICAR, but according to the agreement, they don't have a say in the content of the presentation itself. So do we really need an adjunct to angiography? What's wrong with the conventional imaging techniques that we have already? I believe all of you know what's the problem. The conventional angiogram needs contrast with all of its complications. It's a 2D image, not 3D. You can never know in such an venogram if you have another picture whenever you change your projection. The wall of the vessel itself is not seen. You just see a filling defect. You don't know what's exactly going on the wall. And you cannot measure the diameters accurately in such an aortic aneurysm here. It could be like that. You don't know where is the actual wall of the aneurysm. I will go quickly among the different territories of the vascular tree to demonstrate what are the benefits you may get by this imaging tool. In the aorta, you get the true diameter. You can visualize the orifices of the branches and locate their site. You can know where is the bifurcation, especially at the iliacs, and most important is the aortic wall lesion, the pathology itself. You can visualize the dissections, the plaques, and any ulcers. I'm going to present quickly this case here to demonstrate how I got the benefit from using the 𝗖𝗿. This was a 58-year-old male with a AAA, and he had an obstructive uropathy from the aneurysm itself, which made him in renal impairment. Actually, we did not image him with a CT angiogram because of his renal functions. This image here is an MRA, and it was actually difficult to make a proper planning for him because of depending on DICOM images from an MRA. Actually, this was the first time for me to make it with the company, but we managed to have some sizing. We were not very confident if this sizing that was intended to do for a CT, according to the software manufacturer, if this will succeed even with MRA DICOM images. So we proceeded to the plan using 𝗖𝗿 together with CO2 angiography. Here you can see the ostia of the vessels, the celiac. Later the SMA will emerge now here. And now both iliacs, both renal arteries. So you can know exactly where is it and put your tip of the catheter here. The video below on the left is just showing how to manipulate the catheter, how to change your orientation in order to bring the SMA at 12 o'clock whenever it's possible to facilitate imaging of the ostia. Once you are at the level of the lowest renal artery, you can continue your procedure. In this case in particular here, we have the tip of a catheter left in place as a marker because we just depended on a CO2 angiogram, which is not very clear. As you can see, we barely see the left renal artery here, which is the lowest renal, but you can see that the tip of the catheter is corresponding to it, and we started deployment of the device. This continued as well as a control angiogram or control 𝗖𝗿 imaging here. You can see the ostia, and then here are the renals, and then after the renals you can see the device itself. So we are properly placed, and now it's in the iliac limb. At the end of the graft we will be outside the graft and then in the iliac. And eventually, here is the bifurcation, which is again confirmed with the CO2 angiogram. So we continued deployment of the device in 2012 without any endoleaks. And when it comes to aortic dissection, I believe this is the most important indication for 𝗖𝗿, because the challenges in aortic dissection are mainly in the actual diameters of both true and false lumen and identification. Where am I? Am I in the true or the false lumen? So in a video like this one here, you can see the true lumen here is compressed, but you can notice the ostia emerging. Like here. Actually, this is not a complete case, but you can notice the vessels, and you can make your planning according to that. Many people have compared the use of transesophageal echo in comparison to the IVUS. The TEE is actually cheaper, readily available in every hospital. It detects endoleak very well, but it cannot visualize the abdominal segment like the IVUS does. And the IVUS is more user-friendly. You are steering it yourself, not depending on an operator who is outside the patient and you are trying to tell him what you need. No, it's a different story, because you are the one who is imaging actually, and you know what you want. And finally, it's more accurate sizing, obviously, because the catheter stays in the middle of the lumen and circumferentially has these ultrasonic waves, so you are sure that these diameters are true, not like whenever in the TE it's an oblique angle and you cannot tell exactly if this is the true, or this is the correct diameter. In venous occlusive disease, venographic images are very difficult to interpret. Here you can see the relation between the left renal artery and vein. Maybe here it's not very accurate, but when your eyes get used to the IVUS, you will know that this is the artery and this is the vein. In the next image, now you can notice how this is compressed here, like in May-Turner syndrome. And whenever you deploy the stent, you can see if it's properly deployed or not. This may be not very visible by the conventional venogram. Now, at the end, I will talk about the peripheral arterial disease. This case here was done last week in my hospital, and you can see the lesion in the proximal superficial femoral artery, in the upper 2/3 of the superficial femoral artery. This can be seen as well here in the IVUS image, with the thickening of the wall around the catheter. This is not very important, but the coming images are even better. Here we can see an eccentric lesion with flow beside it. And after dilatation, whenever you look to such an angiogram here, you may ask yourself, is it enough? Am I done? Should I stent? Should I do another balloon dilatation? The image could be adequate for many of you, but when you look by the IVUS, what do we have here on the right side? Unfortunately, we have a thrombus, and it's actually protruding inside the lumen. So we detected something that could have been missed and may lead to thrombosis later on. Actually, we managed this case with lytic therapy, but just for half an hour. It resolved everything with the use of TPA. Another example of the imaging benefits, if you look here, we have a small extravasation, a small perforation of the vessel from our wire, and here we can see it actually. And lastly, when you look to the tibial vessels, whenever you look to such images, you try to use your experience to know the actual diameter of these vessels. You may be surprised when you notice that many of these small vessels are more than 3 millimeters in size, sometimes 4 millimeters. It will help you in deciding the proper size of balloon you may need. So to conclude, IVUS is extremely helpful in measurements of diameters, assessment of the vessel wall morphology, localization of orifices, ulcers, dissections. It's strongly indicated in aortic dissection and venous occlusive disease, but it has as well many other uses in peripheral arterial disease and aneurysmal disease. Thank you for your attention.
Thank you, Professor Dr. Ahmed Sayed, for your eloquent speech. And now the discussion is open to the floor. If anyone wants to ask him.
Ahmed, thank you very much indeed. Great presentation. Are you aware of anyone who is deploying EVAs totally IVUS dependent?
No, I never heard about totally depending on the IVUS. But what I find is amazing to the combination of CO2 with IVUS and get rid of contrast. This is a big hit, which I believe is very important.
Thank you.
Well, of course, Dr. Ahmed, we were getting on the way about now it's 5 years ago. We were about to use zero contrast with the use of the IVUS. But still at that time, we were not confident enough not to use a small amount of contrast material in order to check before deployment, in order to make sure that we have no later on type 1A interleak.
And how limiting is the cost of IVUS in Egypt? How does that translate into its availability to your practice?
Well, with the condition of the changes in prices, it's extremely difficult to tell how feasible this will be in the coming period. But I remember a couple of years ago, it started to be available in my university hospital. It was used in very selected patients because the number of catheters was not a very big one. Actually, to present these cases, the company offered to demonstrate free samples to use them. But I believe we're going to have hard times regarding all tools in the coming times because of so many economic problems. I cannot tell how this will affect the use of the IVUS, but my last slide points to the fact that whenever we are doing aortic dissections and venous occlusions, it's extremely important. It's worth everything. Whenever I'm trying to benefit from other indications, I may consider the cost seriously.
Thank you.
Dr. Ahmed, in May Turner, IVUS may have another advantage because we usually get the upper end of the stent inside the IVC, but sometimes it go more and more, including the other side. IVUS in this position may be very helpful to localize the extent of the stent inside the IVC. Okay, thank you.
Yes, and I'm expecting Dr. 𝗏𝗏𝗀𝗀 will present in his talk tomorrow about veno-occlusive disease. I believe there will be demonstration of what you said because it's really important in venous disease. But I didn't have a nice case to demonstrate.
But what do you think is the limitation of use of IVUS in Egypt other than money? Needs more training, I think.
We need a larger sheath size, but I don't think it's a big limitation. I think the economic burden is the most serious one.
Okay.
Yes, Dr. Essam Osman, please.
Yeah, can I just follow on to that? I mean, I do understand that in May Turner and venous disease, IVUS is a nice extra tool, and everybody says you have to use it. We don't use it. When we do a lot of iliofemoral DVTs and May Turners, and by and large we get away without jailing any of the right iliac. I'm not sure that jailing is such a big deal, really. I mean, people say it is, but if you're using an open cell stent, it's not a big deal. I just wanted to come on to Ahmed's question about using IVUS for EVAR. Do you not think CO2 is probably better for an EVAR in a patient who you can't give contrast than IVUS? Because I've seen one done with IVUS at another hospital, and he came back to us with a whopping grade 1B and sac expansion within a year and a half. So I wasn't very impressed.
So the question.
So have you used CO2 angiography for EVA?
Yes.
Yeah. Do you not think that's better than IVUS?
I don't compare it to IVUS. I'm considering them complementary to each other.
Okay.
And if the question is about the CO2 angiography compared to the conventional angiography, there is growing evidence that we might use it, and it has a good sensitivity in detecting endoleaks. But talking about myself, frankly, this was my first case to do both of them. So it gave me a lot of confidence to do it while I have the catheter like that pointing to the left renal artery. So maybe later I will use CO2 alone, but I think both of them together is very beneficial.
Yes, thank you, Professor Ahmed.